Good afternoon, Mr. Gill.
Good afternoon, my lord. The next witness is Alex Collop.
Good afternoon, Mr. Collop.
Good afternoon.
Thank you, my
When
lord.
you're ready, Mr. Gill.
Thank you. Mr. Collop, will you provide us with your full name, please?
Alex Collop.
Yes. And you provided us with a statement. The reference to that is SCIWT 0361 and then 501. And just as an introduction, you're agreeable that that statement is produced and that the evidence today is recorded, broadcast, and published.
I do, yeah.
Yes. Can I emphasize at the outset, because you've given a lot of detail in the statement, particularly detail of matters that have been referred to you or you've been informed of. And you've given a great deal of detail in relation to that. And can I just indicate that all of what you say in your statement will be taken into account. But obviously in the course of our discussion today, we will just touch on some of those issues. Yeah. Now, you are giving evidence today as the head of operations of the organization called Circle. And you provide an overview of that organization at paragraphs 6 through to 26 of your statement, and we'll look at that in a few moments. But first of all, your personal background. I think you say you've got 24 years in community-based work. That's at paragraph 4, which has been mainly in youth and family support work.
That's correct, yeah.
Just tell us a little bit about Circle and how it operates, please. Just tell us what it is.
So Circle are a registered Scottish charity. We're a family support charity. We have our head office in North Edinburgh. We were invited to Scotland in the 1970s by then Lothian Council. We were then part of a UK-wide organisation called Family Support Unit. And then we became an independent charity in 2007. So we have a number of teams that are linked to particular geographical areas. So for example, 2 teams in Edinburgh, a team in West Lothian, a team in East Lothian, and a team that works across the Central Belt and the west of Scotland.
And what is the principal areas? I don't mean geographic, I mean the areas in which you specialise.
So as a children's charity, I mean our core aim is to ensure that children can safely remain with their families. So we have a number of areas we're very well known for, one being substance use support. Another area is support for criminal justice, where parents are imprisoned or have a community order. But we also do some more localised early years and primary education-based support. So those are the kind of key areas for us. Within all of those areas, there's probably subsections of kind of themes such as domestic abuse, and many of our families will be significantly affected by low income and poverty, and that would be across all our teams.
Thank you. Excuse me. Can you just give us an indication of the number of staff that the charity, I suppose, employs?
Currently just over 60. At the time of the COVID pandemic, it was less, so it was closer to 50. Yeah.
And one of the points that I think we see throughout your statement at various stages is the importance of personal interaction with individuals and families that you're dealing with.
Yeah.
And I suppose particularly in the context of addiction services, it is important to create a relationship of trust between a representative of Circle and those that you are seeking to assist.
Yeah, absolutely. I mean, some of the terminology that may be used is we're relationship-based practice, so we do we know that we have the best chance of making a difference within the work we do if we build a strong, trusting relationship with the families we support and the people that are around them, and with other organisations that we work in partnership with. So yeah.
Now, you've emphasised, and indeed you've already said, that you're a family-based support organisation. I suppose that one also thinks in the context of addiction issues of individuals who have addiction problems who may not be part of a wider family or may not have, for example, children. They may just be single individuals. Do you assist with those people, or is it just families that you
Just families,
okay.
yeah, and some of the work we do that maybe within the contract as it's the service specification is that, you know, the children would need to be living with their parents, or there's a plan for the children to be rehabilitated into the family home, so that can be part of our kind of our contracts we provide. So it is, all our support is within the family context.
Right. Okay. I suppose one of the areas I want to look at in terms of impact is the impact on your organisation, not just on the people you assist. Excuse me. So the prior to the pandemic, well, let's go the other way. Once the pandemic hit in early 2020, what differences did that make, just in general terms, to the way in which you and your colleagues in Circle had to operate?
It was really significant for us. So our teams will tend to support families in the family home, children in their school setting or community settings, and you know, from my memory of sort of late March of that year, that all had to stop, and we were unable to do that. So it had a significant impact on us and what we know is effective in supporting families, what families really appreciate, and the way we approach our work. So the immediate impact was huge, and there were, you know, very experienced staff who felt they couldn't perform their role initially. Over time, that kind of changed because we developed ways to be able to support families and to be able to meet with them. We would call them walks and talks, so we would meet and we would go for a walk with a family member or with a child. We started to utilise MS Teams and Zoom, WhatsApp, to ensure that we were able to keep in contact with people and respond to what they needed. And there were significant needs around food insecurity, or certainly within addiction services, access to prescriptions, for example, huge levels of anxiety, you know, particularly acute for for families we were supporting who are often very marginalised anyway. So yeah, initially though, and my memory was, everything changed. I think it was 23rd of March from memory, and suddenly we weren't entirely sure how we would do the work we did effectively, but we got very creative very quickly to ensure that we could. A lot alongside that was, there was money coming down to certainly the voluntary sector from the Scottish Government, from trusts and foundations to distribute directly to families. So we were able to help with getting hold of tablets for children so that they could link into their schools, making sure they had enough data to do that, providing food boxes, printing off menus and providing the ingredients. So lots of ways to kind of stay connected with families and with people, and reduce or mitigate some of the impact that we were all feeling.
Can I just be clear? The families that you support was and is addiction issues within a member of that family, an essential part of your engagement with the family, or would you support a family where those issues were absent?
They would tend to be parents in recovery,
Right.
although obviously the very nature of recovery is that there can be relapses and that can break down.
They say you're always one step away from relapsing.
Yeah, and we would often be working alongside a statutory partner, such as Community Addiction Services, which would be NHS staff who would be meeting with parents around managing their recovery, and they would be the prescribing service. So we don't, we may have some interaction with and work alongside those services, or there may be, the children may be allocated to a children family social worker because of a level of risk associated with parental substance use, and the very nature of the work is there can be crisis within a family, there can be relapse, but we tend to be working where there's a level of recovery, or linking families into recovery services, of which there's a number within any substance use partnership. So we work in partnership alongside those services. We try and marry the parenting alongside the recovery. Yeah.
One point, you've touched on it. Paragraph 34 of your statement, you talk about Circle adapting and move to a blend of telephone, online, doorstep, or walk and talk support.
Yeah.
Now, you've told us, and I was going to ask you about walk and talk. It's just what it says.
Absolutely, yeah. We, particularly during the lockdowns, obviously it wasn't appropriate to go within homes at times, or there was uncertainty about doing so. So what we would routinely do, unless there was a need to go into a family home due to crisis, is we would do walks and talks, and at times it was, it's a really good thing to do because it builds in routine exercise alongside having a talk. Some of the challenges there where we often have to have a very confidential space, and walking in the local park doesn't always allow for that. So there were, it did have its real challenges, but we were responding to what we understood the restrictions to be. We had some staff also who would have underlying health issues themselves, such as asthma, so we were very careful to ensure that we were not putting staff in any position that put them to at risk.
Yes, and paragraph 35 of your statement, you talk about the interaction with NHS health visiting staff. Can you tell me how you do it, or you did, both pre and during the pandemic, marry your services with NHS visiting staff?
Some of our teams that work in the early years, I mean, they would routinely be working alongside health visiting colleagues. We would get referrals or requests for assistance from health visiting teams. So we already had a very strong relationship with NHS health visiting teams and other teams, substance use teams, mental health teams. We had a particularly strong relationship with one NHS health visiting team, and we were just talking about how they're a home visiting service. Obviously, that's what they do. So we were talking to them in great detail around how they were managing that, reducing the risks, getting access to PPE equipment, and learning from each other. It was a very live environment, so we were just really keen to, and we would do this also with social work teams. We had guidance from social work, and that's what we were following, because they also would routinely be home visiting with families. So there was a particular an NHS health visiting team that were had good connections with, so it was a real kind of strong route for us to get kind of information and updates.
Now, paragraph 37 of your statement, you talk about where there was a need perhaps to go into a family home to provide the service that you were providing, and what you were doing was balancing the risks to staff with the level of need in the family.
Yeah.
I can imagine that could have been a very difficult balance.
Absolutely. I mean, very typical examples would be, for example, a mental health breakdown for a parent, and just the need to, on balance, to go into the family home and to support them to get what they needed at that stage was something we would consider. So we had a policy and a process in place where staff could make that call, and sometimes you're arriving at a very live situation, an arranged home visit, and somebody's in crisis, so we had to kind of balance that. Or, for example, if it's one of the staff who would not be able to go into that environment, then we'd look for staff support, so that for example, a staff member with asthma. So yeah, we were having to make those calls, or if we had a concern for a family around a potential relapse and hadn't seen a child, then that might be, again, a call we'd make alongside a social work team, just to ensure that we were able to be confident that a child was safe at that time. Yeah.
Of necessity, were these decisions to go into a home left to the individual worker?
No, so we have a line management system and a protocol in place. If there was an immediate emergency, I mean, we have on occasion, unfortunately, had to, not necessarily within the pandemic, but we have had to call an ambulance. On an emergency basis, that would be a call that would be made immediately by a staff member. But if it's more subtle, I have a concern for a family, but I'm not sure, then we would follow protocol and on balance, and maybe liaise with partner organisations who may have seen the family more recently, and then make a decision. So there was a line management structure and support in place. Yeah. Thank you.
Paragraph 41 of your statement, you talk about the provision of what you term practical support, which you identify as assisting in the distribution, or assisting carrying out the distribution of resources directly to families through either energy or food vouchers and art and well-being packs for children and parents, digital support such as tablets. These, in blunt terms, Mr. Collop, cost money. Mm-hmm. Where were you able to get funds to assist in doing that?
So there were grants that were coming down, from the Scottish Government or through trusts and foundations, maybe where we had a grant from our trust. They would say we're setting aside some money to assist with families who have the greatest need. That money would come to us, and we would, workers would check with families what their needs were. The situation when children were out of school was, for some families, that reduces their access to what can be their only meal of the day. That is the reality for some families. Yes. So what we were doing was, maybe the greatest need was to have access to food. But then in the winter, when families were home, the heating was on, so the energy costs were going up. So on balance, it was looking at what would mitigate the worst impact at the worst time. So I'm thinking the initial lockdown, and then there was a lockdown in late December, early January, and
Christmas lockdown.
Yeah. Again, that was such a challenging period. I think obviously for us all, but in particular where families didn't have the means to pay for some items, or had limited access to school meals, for example.
One of the points you've made, obviously, which is, I suppose, inherent in the provision of assistance in the addiction situation, is the obtaining of medication. Mm-hmm. And I suppose we all have in mind the need for methadone in particular. Was that a particular issue or worry for those that you were assisting in obtaining those that medication, and were you able to give them, as it was, at least some comfort that they would be able to get that?
For some families it was. So there may be a number of factors that would influence that, such as distance from the local pharmacy, underlying health issues, having COVID itself and not wanting to obviously go out. There was a lot of high levels of anxiety for many people, and it would be, for many of the families we support, there's a high level of diagnosed mental health issues, so obviously the level of anxiety was quite acute. So we did support, and often it would be alongside, with explicit consent from the person whose prescription it was, and alongside other statutory services. What we did was we would go and pick up a prescription, and we would deliver it, because it's such an important part of somebody's, many people's recovery, and the level of vulnerability of it's not accessible is huge. We did have one unfortunate case where a pharmacy was not open on a Saturday due to the whole team being ill, and getting access was particularly challenging for that parent over that weekend, and that was the kind of really acute impact that we saw. So it was very real for a number of families, not all families, but a number. Yeah.
I think one of the issues in providing medication is that it has to be done, as I understand it, securely. And very often I'm thinking particularly of methadone, has to be taken in the presence of the pharmacist, so that essentially somebody doesn't pocket it and go and sell it. Was that something that you were doing, or you just had to be able to provide
there would be other prescriptions, not methadone, to my knowledge.
In paragraph 46 of your statement, you talk about I suppose, a positive aspect of the way in which Circle responded to the situation. I think you've indicated already very early in your evidence the rapidity with which Circle had to respond. But you go on at 48 to talk about perhaps the converse of that, where you say, for a few families there were acute issues, and access to the normal full range of supports and protective factors was more challenging for the families. This often became the difficult scenario of those families most in need of support, being the furthest from the support. Can you just explain that a little?
Yeah, so when I'm talking about supports and protective factors, going to school would be one of those protective factors for many children, and families, that routine and
constant feature in their life.
Yeah, absolutely. Or the local football club running, or other areas that would be part of their community, part of their everyday life. So lots of things just kind of were not available. Lots of things like that were not available. I think, it still would tend to be the case. It's not just a feature of the pandemic, as sometimes those who would most benefit from support can be furthest away. There can be barriers to that, and that may be around acute mental health issues or experiences of having support before, or poor experiences in an education system. So, there's again, it's very different for different families, but we're very persistent in our support, so we would continue to reach out to people. We don't have a system where if somebody's not in contact on 3 occasions, then we would close support. We would look to ensure that it's available. It just might not be the right time for them, and it might not be something may have happened that week that's just a barrier to them accessing support with us. So we would try and reach out, and we can do that in very creative ways again. And having access to practical supports sometimes can be a route in for families, because you are providing a whole range of support. We would call that holistic support beyond the kind of emotional or recovery. As we are looking to provide well-being packs, and we're thinking about you as a person, and trying to meet your needs in a broader sense.
I think you probably answered this question in the context of what you've just gone on to say. Did I pick you up saying that you were quite persistent in checking on people?
Reaching out to them,
Right, okay.
Yeah.
Put it that way is probably a more delicate way than I have. So,
our support is voluntary for families. We're not a statutory service, so we need to kind of keep that balance in play as well. But we're also a limited resource. So if we have no contact with the family for a period of time, then we would write a letter, or we would try and reach out in another way to kind of ensure that, because our support might not be needed at again, we put a high level of autonomy with families and build an understanding of, because the support's got to work for them, and it's got to make a difference to them.
One of the features throughout your statement that I picked up, and correct me if I'm wrong, is the concern that you as an organisation have and had about the isolation that families were suffering. Now, I suppose, given the common denominator, if I can put it that way, of substance abuse, the isolation can come with that. But it also, I suppose, may come with a tendency to associate with people with the similar issues. Can you indicate how and to what extent the pandemic impacted on the people that you were principally helping in terms of their isolation?
Yeah, I think the fact is that we were all isolating in a sense, so they were, as the general population, much more isolated. And I think actually for some people it was a more comfortable position for them, because it was somewhat easier to manage those associations they have, or associations they're trying to break or leave behind. But again, we were seeing an acute impact for children, for young people, and that carries through to today. As we know, there's unfortunately high proportion of children and young people that haven't returned to school since the pandemic, and that remains of huge concern, and the mental health impact of being isolated or isolating, and we try to reduce that through the various means we kind of looked at earlier, which was kind of regular check-ins by phone or by a WhatsApp call, or going to somebody's house to drop something and meet with them, have those walks and talks. So we made those kind of very routine for families, for children. For some children, it was seeing a circle worker was the only time they would be leaving the home of a week. Unfortunately.
Right, now at paragraph 53 and following, you set out a number of issues and matters that have been brought to your attention by, I think, others working within Circle, and you provided them under sort of general headings, but provided them by reference to the geographical areas in which Circle operates. So it's West Lothian, East Lothian, and Edinburgh Harbour, which, as I understand it, Edinburgh Harbour is just Edinburgh Central, is it?
Edinburgh city-wide, the whole city, yeah.
So, as I say, these are detailed points that you've made, and they're very, very extensive, and the inquiry will have regard to all that's said there. But I'd like to ask you just a few things about some of these. Now, we'll have to use the page references and the bullet points for this, because they're not numbered. But if we go to page number 0007 in the bottom right-hand corner, which I think my colleagues behind have got access to, and if we look at the third bullet point under paragraph 53, you make reference to food deliveries, and I think you've told us a little bit about this, but you indicate there that in West Lothian there was a considerable increase in food parcel deliveries, not necessarily being delivered by Circle, but being delivered by other organisations.
Yeah.
And again, I think you say that where the situation was that children were not in school, these could be one of the few opportunities that they could have to have a decent and possibly hot meal during the day.
Yeah.
Okay. Of other significance on that page is the following bullet point that I'd like to ask you about, and this relates to residential rehabilitation. Now, could you explain, first of all, what role you have, your organisation has, in assisting or organising residential rehabilitation for somebody who's suffering addiction problems?
Yeah. So we're not directly involved. We'll support the process, certainly.
Yeah.
But you would have largely NHS teams who are managing that process, and it'll often be, somebody's recovery and access to rehabilitation processes. It's a very well-assessed process, because somebody needs to be at an appropriate stage of their recovery. Sometimes it can require medical overview, and oversight. So we would often support, and it may be supporting the children to understand where their parent is going. So it's the whole family we are supporting. And often it can be a 12-week program in residence, so there may be some additional supports that go into the family at that time, or we may drive somebody to the setting. So there's certainly settings in Edinburgh that we would at Astley Ainsley, for example. So yeah, that's our involvement. So there's people or professionals that are more directly involved, right, or would make that referral into that residential rehabilitation setting.
You say that at the bottom of that bullet point that there's often a short window in which to do this. Is that connected with the individual who is going into rehabilitation? Is that connected with their willingness to engage with that?
I think that will be a factor, but I think the biggest factor will be the availability of a space.
Yes.
Yeah. And a space may come up because very quickly, because somebody has left suddenly. So not I would understand not all people will stay in the setting. So a space may come very quickly, and you need to prepare if you're on a waiting list, I presume you then suddenly have an opportunity to go in.
And in the context of the pandemic, what was the position about getting somebody into rehabilitation?
Our understanding was, I think like many systems, it slowed down. There were obviously considerations around the physical settings and safe distances. Visiting or access to family would have been, somewhat restricted. So those were, but I think the kind of system took time to adjust, and there were periods where it was much more fragile, during the lockdown.
Right, could I move on to page 8, please, and the third and fourth bullet points at page 8. They're slightly different, so I'll take them separately. In the third bullet point on page 8, you refer to the issue of online support not always working for various of those you are trying to assist. As I understand the way in which you were having to work, with the exception of doorstep visits and walk and talk, a lot of what you were doing was either by phone or online. For those people who had difficulties, either with managing if it was being done online, either having the facilities to do that, or alternatively not wanting to engage in that way, was there any way of resolving that as an issue?
I mean, with difficulty, for some people, having a meeting online actually suits them. It's fair. You don't have to travel anywhere, and it's a more comfortable space for some people. But for other people, we did run online groups where some people would choose to have their camera off, or would not necessarily say anything, but would feedback after that it was beneficial being in that space. So there's measures you can put in to make it more comfortable, but it was certainly just very alien for some people. It's very new for many of us, I think. It took a little bit of adjustment. So yeah, it was mixed, but it was a huge challenge for some people. And I think because of their relationship with people, being able to be in a room with somebody and look them in the eye, and all the kind of the very kind of human elements that we have when we're that are taken away from us when we're online, that was really challenging for people.
Probably a development of that point is the fourth bullet point on that page. I should say that this is all in relation to East Lothian, but I think that a lot of these issues are common throughout many of the, or several of the matters that you refer to. And this is, you go on to talk about mental health and psychological services. And you say that they were not great anyway, but they became even worse for families.
Yeah,
there's that where or when you're given a 20-minute phone call, and this was not appropriate for some of our families. And you mentioned especially dads with significant issues.
Yeah,
Can you just give us a little more context of that, please?
Yeah, I think that there's definitely two words missing from there, which is access to. It's not that the mental health or psychological services are not great. It's that the access to. I mean, we know that that's one area.
I'm sorry, I was reading that.
Yeah, I see how it reads. That they're very effective, and what works really well for families is being able to meet with the mental health and psychological services in person, but accessing them is very difficult within children's services, within adult services. There's a lot of capacity issues. We know that waiting lists. A lot of feedback that we got was that the kind of phone call or a Teams call with those services just wasn't really working for people. But it's also not appropriate for those more clinical services to go to somebody's door in terms of a confidential space, or the walk and talk was not so appropriate. So again, I think that was a real challenge for families. We had a little bit more flexibility, and we had a lot of those kind of practical supports we were offering. So the rationale for us to go and drop some food or some energy vouchers, whatever it may be, at a family home and go for a walk and talk was a bit stronger than the psychological services, where it's much more around acute mental health supports. I mean, especially dads, I think there were, and it links to other areas, but for some of the fathers we were supporting who were in separated families, it was kind of it was a very challenging period for them because they had limited contact with their children, even if there were no legal orders in place. So that was some of our colleagues in East Lothian team saw that as a kind of particular area of need. Yeah.
I think you give a particular example of, it's at the bottom of page 9, the last bullet point. Again, this is in relation to Harbour, Edinburgh, but you give the example of, again, a male who was in a lot of distress, separated from his children, and you explain that, and you say this was challenging to support due to the level of distress. This was done through telephone calls and investigative work to figure out which service had given the man support previously. His children were accommodated in different geographical areas, and trying to keep the father linked into all of that was affecting his mental health and well-being. A lot of working factors trying to coordinate all of this, but the partnership managed to meet the individual's needs. That's a partnership between you and presumably the mental health.
It would be the addiction services, and so that's northwest Edinburgh. So you would have community addiction services. So there's NHS. You would have partner agencies, recovery services such as CGL, Turning Point, who we'd be working alongside. Yeah.
Okay. Can I move on to something again that you had reported to you through your colleagues in East Lothian? This is page 12. And at the top of page 12, there are 3 bullet points, probably 4 bullet points, which relate to pregnancy and antenatal services. Interestingly, you say that this is in the first bullet point, there were no antenatal classes and mothers couldn't meet up. Circle workers can see the impact of the pandemic on those babies who are now 3 years old. Can you explain that a little more, please? Again, I'm appreciating this is something reported to you, but...
Yeah. So, I mean, we have a number of our pregnancy and postnatal services will run groups, and those can be groups for, again, very isolated parents with new babies or who may not be accessing universally available groups. But during the pandemic, obviously, that we couldn't do that, and it was very challenging for parents with babies, because doing something like a walk and talk during the winter with a newly born baby was not appropriate. So again, it was a particularly acute situation, but what babies and parents get from the classes, from meeting, is a lot of socialisation and attachment, and that's a lot of the work we support, and that was taken away. So it's obviously a significant development time for a baby. So yeah, that was an area that again was very challenging.
You mentioned, and I think we can probably all imagine it, the difficulties where a woman with either personally with addiction problems or living in a family with addiction problems was required effectively to give birth on her own without the support of either a partner or another relative. Because this was obviously something, as you mentioned it in the second bullet point there, this was something that was happening.
Yeah, this is certainly our colleagues, families they support. This was the case. Yeah. I would be going into a birthing unit within a hospital, for example, and there were some restrictions there.
Now, I think you do give a more detailed example of that. We go to page 17, and the final bullet point under East Lothian on page 17 of your statement begins, during the pandemic there was an example. And that's, I think, a situation where there was an ongoing problem, which in the end of the day really couldn't be resolved, as I understand it.
Yeah, I mean, there's a huge amount in that individual bullet point, but yes, this was obviously very complex, multiple factors, health factors, domestic abuse, housing issues, so really, really complex. And there was a huge impact there. We were doing what we could. I think, it says at the end, and around as much practical support as possible. But our our interactions with the family were reduced. It was around the restrictions. So
I think within that example, there are some of the put bluntly, awful circumstances.
Absolutely, yeah.
That can and did occur, where this particular individual had, I think, 3 children. She had a telephone and that was her means to try and assist, added to her own personal problems. She had a telephone on which to try to assist her children in home learning.
Yeah, that wouldn't be an isolated case, unfortunately. Yeah.
Okay, thank you. Can we go back, for me, to page 15 of your statement? One of the interesting points you make there, again, this is under the heading of Harbour, Edinburgh, and it's the 5th bullet point down from that sub-heading, and you say there that in an initial assessment, it was hard to assess if families were telling you the full truth about their home situation, because it could be hidden so much easier during, and give the example of lockdowns, isolation, staying at home. Was that an issue that cropped up for your workers?
Yeah, for some workers, for some families, and there can be very complex situations that we are involved in terms of assessment, and that can be around coercive control, yes, domestic abuse. So, yeah, or a fear for a family that's knowledge of something happening within the family would result in the children being removed. So that's an ongoing, that can be a very kind of live situation for us, but it became particularly acute when you're not able to do a full assessment because of the restrictions that we were all under.
I suppose perhaps a related issue to that is you have a different relationship with the people you are helping than those who are perhaps statutorily obliged to protect children. Your relationship is subtly different to that, although it may involve similar issues. So to a certain extent, you have to preserve the trust of the individuals that you're working with.
Yeah, I mean, to be clear, we have the same responsibilities
Yes.
to the children and the adults, and very clear guidance around that. But yes, I mean, if a family or a parent was to say this support's not working for us, whereas they can opt to for support to come to an end. That wouldn't necessarily be the case if a child's allocated a social worker, obviously. There's legal measures in place.
Another point on that page, Mr. Collop, it's trying to count down, seventh bullet point, you say there that some vulnerable people were given lots of practical support, and you indicate those ones you've indicated: money, lunches, presumably vouchers, so on and so forth. And you say, although this is good to an extent, it often wasn't supportive because it wasn't sustainable and was eventually taken away.
Yeah.
Explain?
Yeah, I mean, initially there was, and I know many organisations who would have received grants as we did, but obviously as the pandemic came to an end, that came to an end as well. So, as did furlough and other supports to, and as children went back to school or things returned to some normality, I think it set something. I mean, it's a hard point to make, but maybe set some expectation that there would be ongoing support, and it's not something that could be maintained or sustained.
Obviously, support in a practical sense, and perhaps a material sense, is only part of the support that's necessary. The other element of the support is the emotional support.
Yeah. And a lot of the support needed to be sustained. I mean, we went from a pandemic into a cost of living crisis, obviously. So there a number of the issues didn't go away, but there was a level of support initially within the 2020 and throughout that kind of second lockdown that was more readily available.
Just one final point in relation to the examples that you give. That's in paragraph 56, and it's something you mention several times in the information that you have been provided with. And that's the increase in drinking as an addiction problem. Was that something that your workers were reporting to you as a substantial issue?
Yeah, anecdotally, but I mean, we know through partner organisations we have who have support hotlines. We know the level of the number of people accessing those supports increased really significantly throughout the pandemic. We know the level of alcohol intake in the general population increased. So that was it was the same for a number of the families we supported. Yeah.
Now you've provided us very helpfully, Mr. Collop, with your reflections on recommendations, and again, these are all matters that we have regard to, but I think, as I've probably discussed with you, there are only certain things that this inquiry has the power to do, but we are mindful of what you say. Just taking one of the points that you mentioned, and that is looking forward in the event that there is another pandemic of similar proportions to that which we've gone through. Do you consider that the voluntary sector should have a vital role to play in that any further pandemic?
based on our experience, and I mean, I would talk with giving credit to a huge number of organisations I know who responded very quickly and very ably and made a huge difference in the first pandemic. Yes, we have a vital role to play. We're often embedded within communities. We're part of the communities that we provide the support within, and yes, we play a vital role. But we also live with a lot of insecurity around funding, or funding can be short term, and that builds in. That doesn't build a great deal of resilience within our sector, and therefore it impacts within the communities. So I'm probably tying two different points together, but we responded very well, and I would fully expect we would do again. Yeah.
And do I infer from what you say and the tenor of what you say in your recommendations that you would want to see the voluntary sector having a more prominent role in preparing for any future pandemic?
Absolutely, yeah. We have a great deal of learning. We've learned a lot, and we want to kind of share and be better prepared for that eventuality of it. Hopefully it doesn't happen again. But we would. We've made a lot of learning. I think we need to all. We haven't, my view, quite had the time to kind of consolidate a lot of that learning, because we've gone from one crisis to another. Is the reality. But given some time and the opportunity, we have a lot to contribute. Absolutely. Alongside other partners, education, health, social work colleagues. Yeah.
Now, those are all the questions I have for you, Mr. Collop. As with all witnesses, we offer the opportunity, if there's anything further that you'd like to reflect on at this point, this is perhaps an opportunity for you to do that. Not an opportunity to repeat, but if there's something that you feel you would like to emphasise, please do so.
I'm here representing an organisation and a group of people that worked really hard with and responded to what the needs of families were. So I'd just like to give credit to my colleagues in Circle and more broadly across. I've named some organisations in particular areas, but there was an amazing amount of work and through very difficult circumstances that we did. And I'm here representing a group of people, and I just kind of like to give thanks and credit to them, because that's where the difference was made to the families. And to the families themselves, because they did amazingly well through very challenging circumstances. Yeah.
Well, Mr. Collop, thank you very much indeed for your evidence from me. Thank you, my lord.
Yes, thank you, Mr. Collop. That's all. Mr. Gale, we've finished about 10 minutes early. I know you're not taking this witness, Mr. Edwards is. But I'm perfectly happy to start about 10 to 3 if everyone else is ready at that time.
Certainly, my lord, I'll relay that on.
I'm very grateful. Thank you very much indeed. Good afternoon, Mr. Edwards.
Good afternoon, my lord. The inquiry is now going to hear the evidence of Mrs. Karen Leonard, who is now ready.
Mrs. Leonard.
To give her
Good
evidence.
afternoon, my lord.
Yes.
Mrs. Leonard, can you give your full name to the inquiry?
Yeah, Karen Leonard.
Now, Mrs. Leonard, you have provided a witness statement, and you have a copy of that in front of you, do you?
Yes.
Yes, very good. And you are happy for that witness statement to be published?
Yes.
And for your evidence to be recorded?
Yes.
Yes. Thank you. The inquiry reference number of your witness statement is SCI WTO 648, then 5 zeros and a 1. As we discuss your statement from time to time, the screen will bring up the paragraphs that I want to ask you some questions about. Now, can we begin simply by you explaining what your role is within GMB Scotland?
Yeah, I'm a full-time organiser with a remit for the NHS in Scotland, which includes the Scottish Ambulance Service, NHS boards and the NHS 24. The role is to represent members' interests, make sure that their terms, conditions, health and safety stuff within the workplace is followed properly, and organise local trade union organisers within the workplaces so that they are able to represent their members in their own workplace.
Yes. And you have quite a broad geographical area, don't you, as paragraph 6 of your statement indicates. It extends in relation to the Scottish Ambulance Service across all of Scotland, is that right?
Yeah, that's right.
Yes, and in relation to NHS members, the West or Central West Scotland, the Forth Valley, but also some responsibility for Dundee and Highlands and Islands.
Yeah, that's
yes,
right. Yeah.
Very good. Now, just so that we can put in context how you would have knowledge of the matters you're going to speak to, in paragraph 8 of your statement, you explain that quite a large number, some 70 volunteer representatives report to you. Is that right?
Yeah, so we've got about 40, just under 40 representatives with the Scottish Ambulance Service, and the others are spread across the NHS boards. We have 2 representatives in NHS 24, so they deal with the local issues on site,
Yes.
and I would be relying on them, as always, to come to me with information that we should know.
Yes, and that was true both before and after, and during the pandemic.
Yeah, absolutely,
yes.
yeah.
Very good. Now, the GMB and GMB Scotland has a wide general membership in the organisations we're going to talk about, which is the Scottish Ambulance Service and the NHS. In paragraph 10, you explain what the profile of your members is. You want to say a little bit more about that?
Yeah, so I suppose unlike some other trade unions, we have got a wide scope of membership. So from the ambulance service, we cover all roles right up to management, as we do in the NHS. But in the NHS, it will be mainly the facility workers who would be your porters, catering, cleaning staff, and nurses, as well as radiographers, healthcare support workers. We also cover a lot of maintenance workers in the NHS as well. And then in the NHS 24, you've got call advisors and nurses as well in there.
Yes, so you would have, in the NHS, you would have both healthcare staff and support staff.
And support staff, yeah, admin staff and support staff as well.
Yes. Now, at the outbreak of the pandemic in March 2020, in the early stages, there was not much communication from government or management about COVID and its the implications of what was about to hit.
Yeah, even if you go before March, when it was apparent that this pandemic was coming and the workforce were finding more and more that there was there was going to be this pandemic, there was an issue about PPE, there was an issue about what was expected of the workers, there was little training in how, if this did actually happen, how it would impact the workforce and what the workforce would be expected to do. So that probably happened during February and going into March before we had the real serious lockdown.
And then in paragraph 12, you refer to something called the Workforce Senior Leadership Group. And you say that at the start of in paragraph 13, you say at the start of the pandemic, the Scottish Government set up a Workforce Senior Leadership Group. But it was not until April 2020 that the GMB became part of that.
Yes, so I didn't know that the leadership group existed, and at the time it was through our GMB Scotland Secretary, Gary Smith, had been writing to the First Minister at the time and the Cabinet Secretary at the time as well about this lack of communication and what role could the trade unions have. We then discovered that this had been organised and it was primarily set up with the Scottish Government, civil servants, the employers in both the health, NHS healthcare and social care, and then laterally the trade unions.
But interestingly, in paragraph 17 of your statement, I think what you're saying here, but correct me if I'm wrong and perhaps explain further, is that as far as you remember, a lot of the issues discussed in these meetings were more localised. It took time before issues of wider national significance came to be discussed.
Yeah, I think actually what I was meaning to say would be that at those meetings, the senior leadership meetings, it did seem to be more national, big picture things that were being discussed and not so much the local issues.
Sort of the other way around.
Yeah, so whilst we were dealing with the real local issues on the ground, that meeting wasn't really for that purpose. It was more about when they brought in the death in service, when they were talking about shielding.
Yes.
At the time, they decided that they would take away sickness triggers so that there would be across the board, you know, approach to if anybody was off with COVID and how that would work. So they dealt with the more big national ticket items.
Right, and the more localised issues were left to be dealt with on the ground.
Yeah.
Yes.
Yeah.
Now, one of the themes in your statement, beginning at paragraph 19 onwards, and indeed throughout your statement, is problems of communication and I don't want to put words in your mouth, but difficulties in communication between the various stakeholders and involving the unions who had experience of the issues on the ground. Is that correct?
Yes, because we have, through the Scottish Government and in the NHS, we have a partnership agreement where we should all be working in partnership together. And those partnership agreements form area partnerships and local boards. And that's where the trade unions would expect to be able to communicate with the employer about what would be happening and be able to raise our concerns there and also take their feedback and take that back to our members. But a lot of the time at the beginning of the pandemic, there was, because of the changing guidance that would be happening in the UK and then including Scotland, the NHS tended just to communicate with their workforce without running that by the trade unions in any form of consultation. So, and a lot of the communication that would go out to the workforce, one would sometimes be misinterpreted, and we also had a cohort of workers who fall into the facility workforce, which is the porters and the caterers and the domestics, who don't necessarily have access to NHS email. So whilst this communication would be going out through an email to the workforce, there was a lot of workforce that weren't actually seeing this information or communication.
I mean, could we just explore that for a minute? So if your statement, as we will explain in a minute, is structured around three topics. the first of which, and the point we're going to deal mostly with today, is the impacts of COVID on the Scottish Ambulance Service. Okay. But you also deal more briefly with impacts on NHS staff, because many others have talked about that. And thirdly, NHS 24 staff. But just before we do that, I mean, if I could just ask you to say a little bit more about that point about access to email. So healthcare staff, for example, would have access to emails in which they would be communicated with. Yes. But more domestic staff, as I think you call them, or catering staff, porters and so on, would not have that. They wouldn't have their own work email account. They don't have their own work email account. They didn't then. Since then, the GMB have pursued that more, and we are being a bit successful in getting that rolled out. But there still is that issue just now that there are a lot of NHS workers that do not get the same communication as their colleagues. So they would be dependent on the news or the union or word of mouth? Mainly the trade union. They were dependent on the trade union, and they were dependent on their reps. And at the time as well, when the lockdown came, we weren't able to go into the workplaces. So it became a right pressure pot for the local reps to try and get around as many of their members as they could, to make sure that they had the information. You deal with these points in paragraph 20 onwards, and just to repeat, the issue that was particularly problematic was because union representatives were working at home, they were not seeing members, and when that was combined with the lack of many of your members not having their own work email, there were serious communication problems. Yes, the GMB's communication links are fairly robust, and we would always be communicating with our members via email and text where we could, and we would always, we continuously sent out information as we got the changes that were happening. We were always sending out information and surveys trying to encourage people to let us know what was going on in the workplace so that we could pursue their concerns. But it was more difficult not being able to go around the workplaces. I mean, you identified towards the end of this section in paragraphs 29 and 30, and this would be towards the end of the first at the end of the first lockdown in July 2020. You identify, I think, a particular problem with the death in service benefit, which would be payable to the families of workers who had, I think you're saying there, who had died as a result of COVID. Yeah, and that came through the workforce leadership group, where the Scottish Government had announced that there would be a one-off death in service payment if there was an NHS worker who'd passed away due to COVID. At the time, that came with, again, a bit of a challenge, because they were making it certain workers, just NHS, and at first it didn't cover social care, but I know that moved on and it would cover everybody. But I also think that there was a bit of difficulty in proving that you got COVID in the workplace, and this was part of the Scottish Government's category, if you like, for applying this, was that you had to prove that you died of COVID that you contracted in the workplace. Yes, yes. I mean, your trades union colleagues have commented on that a number of times about the difficulty of proof and the problems that may be associated with that. Well, thank you for that, Mrs. Leonard. My Lord, if we now turn to the first of the main subjects that Mrs. Leonard is going to speak to, which it begins firstly with the concerns about the impacts of COVID on the Scottish Ambulance Service. And this begins at paragraph 31 of your statement. And basically, I think the point you're making there is that right from the start of the pandemic, or the impacts of the pandemic in early March 2020, the problems of first responders were immediately apparent and severe. Yeah, absolutely. The ambulance crews, Scottish Ambulance Service crews, were, as we know, the first on the scene
when there would be any 999 calls. Obviously, at the time, there was a bit of panic and people were using the emergency 999 number a lot more, which created stress in the workforce, just with the number of calls they were expecting to go to, but also the nature of the calls, because at that time, the crews had no way of knowing whether anybody was suspecting of having COVID or not. So they would have to turn up at a house and go through their protocols as they normally would, having in the back of their mind that this person could have a serious, they could be seriously ill with an infection that could be transmitted to them, which they would then could be then taken home to their family. At that time, there wasn't much in the sense of PPE, especially not proper, adequate PPE. So, yeah, it was a stressful time for the ambulance service.
And, I mean, in addition to general knowledge and what you were seeing on the news, union members in the Scottish Ambulance Service were raising these concerns that they were dealing with something unknown, yet they still had to be called out to deal with it.
Yeah, we were raising them with the employer continuously, and we had been writing to the employer. We had done surveys among our members where we were getting things like, 90%, I think it was in the pack, 90-odd% were saying how unsafe they felt, 90-odd% were saying how inadequate the PPE was, to the point that our members were so anxious, we wrote to the then Cabinet Secretary to explain the concerns and the fears that the workers had, and how it seemed to be falling on deaf ears from the Scottish Ambulance Service's lack of response, to the point where the Cabinet Secretary at that time wrote back to us apologising for the concerns that our members were facing. Yes.
I don't want to take you to it just now, but you do, at the very end of your statement, or towards the end of your statement, you do deal with the rolling GMB surveys that you were doing of your members about the attention that was being paid to PPE and health and safety at work. And we may return to that later. But if I could just focus on paragraph 32 for a moment. I mean, you mentioned correspondence, and you mentioned there from even before the first lockdown, I think, on the 13th of March 2020, the GMB wrote to the First Minister outlining the concern of Scottish Ambulance Service members.
Yeah.
Yes.
Yes.
And
yeah.
I mean, was there a response to that letter?
I can't remember.
Yeah. So, as that letter, which is summarised there in paragraph 32, indicates, one of the main concerns at the beginning concerned PPE, and then when we come a little later to health and safety issues, specifically the problem of masks. So the inquiry has heard many times, of course, of problems associated with the availability of PPE. And in which way would you say this particularly impacted your members in the Scottish Ambulance Service, this lack of availability?
So the ambulance crews were given the blue surgical masks and plastic aprons, and that was deemed to be adequate and sufficient for any 999 call out that they had to attend. Now, there were certain, at the beginning of the pandemic and the lockdown, there were certain procedures that they needed more kind of a structured PPE to carry out procedures. If people were having cardiac arrest and things like that, you would need to have had your face-fitted mask on. You needed to have a more covered overall. So there were times at the very beginning where sometimes the crews would turn up at a patient's home and couldn't actually do anything because they didn't have the adequate PPE. So you can imagine, one, how stressful that was for our members and the ambulance crews. That's their job, that's what they love doing, but also for the families that would see the ambulance crews turn up and not be able to actually help their loved ones without fully understanding the health and safety impact and the reasons why the crews couldn't do anything at the very beginning. I don't suppose it happened often, but it did happen.
Yes. And you refer to the union's reaction to this. You've already mentioned it at paragraph 36 of your statement when you mentioned the letter that the GMB Scotland Secretary had sent to the First Minister.
Yeah.
And then you go on to explain that that led to an apology
Yes.
from the Cabinet the then Cabinet Secretary for Health. Now, in paragraph 38, you do say there were changes over time. I mean, by over time, what do you mean? Do you mean like over a month or over a much longer period?
A longer period, over a couple of months. Although I can actually remember that even in December 2020, in January 2021, we were still surveying our members about whether they felt then that their PPE was adequate. But going back to the beginning of the pandemic, there was a big problem around the FFP3 masks.
Yes.
And there was problems about the masks having expiry dates.
Yes.
But there was also problems about the actual face fitting of the masks and how these masks should work properly, what had to be done and how they had to be fitted to make sure that the people who were wearing them were protected the way they were supposed to be. So the first thing is when all of these FFP3 masks suddenly appeared, that's my opinion, there was boxes with out-of-date stickers on it.
Yes.
And which our reps were being notified of. They were sending me photographs of it. And we then started to discover that when you peeled back the expiry, the out-of-date ticket, there was maybe another 2 or 3 underneath that.
So to take it chronologically, at first, the blue surgical masks were issued to ambulance staff.
So before the pandemic, the Scottish Ambulance Service should have had access to FFP3 masks,
Right.
but only in the sense that there's a mask, put it on, use it. That doesn't protect you. So the crews felt that a blue surgical mask was of more protection than them just putting on the FFP3
Right.
that didn't have any protection at all. So they used the blue surgical masks while the face fitting was getting done for the FFP3 masks.
Right.
And that was about April that started.
Yes. And once the FFP3 masks, or the boxes in which they were contained, started to be rolled out, then the issue of expiry dates arose.
Yeah.
And do you know where were these masks stored? Were they stored in the NHS system or somewhere else?
I'm not sure. I think the masks were stored nationally in some kind of a portal, but I'm not sure.
Yeah. Now, what was the response to from the union to the use of masks with expired use-by dates?
So it was difficult because you wanted to protect your membership, but at the same time, we had to challenge whether these masks were actually doing the job that they were supposed to do, and that was protecting the workforce. We had been writing to the Scottish Ambulance Service, we'd been writing to the Scottish Government, and we were just trying to establish, had there at some point been a test done that would make the masks safe. Now, I would have thought it's got an expiry date for a reason, and through time, we did manage to contact one of the manufacturers, who was quite surprised actually that one of their masks was still in use because it had been obsolete since about 2014.
And in paragraph 42 of your statement, you mention this. You say that the union emailed the manufacturers, and it became, and you got the response, or a manufacturer, and you got the response back that the masks were obsolete and should not have been used.
Yeah,
that's what you were told.
Yeah, and following that, there had been tests. There had been communication from the Scottish Ambulance Service to say that the masks with expiry date of 2019 had been tested by a whole group of people, but no actual risk assessment. I think it had been tested by, I now can't remember, but it was like the health care people had tested it. No risk assessments had been done, but it was deemed that the masks with 2019 were safe for use. Strangely, some of those masks had the additional stickers underneath that, that went back to 2014 and 2012, and there was no mention of the expiry date going back to that length of time.
Yes. I mean, in paragraph 46, you relate a story of a member who was reporting that the way testing face-fitting masks was done was, as you explained there, the mask was being fitted, there was a spray being used, and if you could taste or smell the spray, then the mask wasn't fitting properly. I mean, was that, when you say a member, was that an ambulance staff member, or was that
That was ambulance staff. So we, again, because of the concerns and the stress that this was causing the crews, because the other thing you need to know as well is it takes time for this face mask, for the face fitting of the mask to take place, and they had to travel to certain areas to do that. People had to be tested on face fitting in order to carry out the face fitting of the masks, and a lot of crews didn't get the time off the road because of the seriousness of the times and the amount of time they needed to be on the road. They didn't get the time off to go and get tested. So that created a bit of concern. So this was coming from our members who, when they were going for the test, it was explained to them what would happen, how this should be, and if they could smell, taste whatever the spray was, then the mask didn't fit them properly. At that time, I think there was maybe 2 or 3 different styles of masks. So if one didn't fit, they would then try another. And if that didn't fit, they try another. So there was one type of mask, I think it was Alpha something or other, that they had most of. So there was a bit of an urge from the Scottish Ambulance Service to say, that's what you push that mask, and, you know, whatever happens, we need to get rid of those ones first.
But there was a more general problem, which I think you would say would apply to both masks and PPE generally, which is that a one-size-fits-all approach was adopted.
Yeah,
as
there
you
was.
say in paragraph 47, for example, of your statement.
Yeah, so that would be, as I said, when we talk about the adequate PPE, for when the crews were going into, they had to give AGP procedures, they were to wear like a suit that zipped up and it had a hood, and they would be wearing that along with the mask. But these suit things were primarily for men, primarily one size. I don't think they came in a lot. They didn't come, there wasn't many small sizes of these suits. So we had a lot of female members who were feeling a bit kind of left out and not being thought of, because they were expected to put on this suit that didn't fit them properly, and they had to adapt that in a way to deal with an emergency situation. And again, they just felt a bit vulnerable.
Mm-hmm. And obviously still needing to do their job, so that these issues with PPE, you say, affected staff morale and staff health.
Yes, absolutely.
Well, that's, I think, all I want to ask you about PPE, unless there's anything more you want to say about PPE in relation to the Scottish Ambulance Service.
No, other than I just think it's quite poor what the workforce went through.
Yeah. Now, in relation to test and trace, there were some other issues in relation to what was to happen if a member of the ambulance staff tested positive for COVID.
So if they tested positive, it would be because they would have had symptoms themselves, and they would test positive. So back then it was you had to isolate, can't remember now, but it was 10 days, whatever many days. But at the time of test and trace, that's when it became, you know, the public became aware that you might not actually have the symptoms, but you could have the virus, and you could therefore be passing the virus on, which was the whole test and trace. If you were with somebody who tested positive, you would then be contacted. There was an alert system to contact you to let you know that you had been in contact with a person, and therefore you should test yourself to see if you had it, and therefore follow that guidance and isolate. The ambulance crews were never notified
Yes.
if they had dropped off a patient who actually tested positive of COVID. The only way that they ever found out would be through word of mouth from another crew, or being back at that hospital and speaking to nurses.
Would members of the, just going back to the email, having a work email, would Scottish Ambulance Service staff have their own work email?
Yes.
Yes.
Yeah.
But that wasn't used to communicate these sorts of matters. If there had been someone in the ambulance who had later tested positive with COVID.
No, they didn't. They didn't contact them at all, as I say, other than if any crew felt that they had symptoms. My personal opinion of that is because they couldn't afford for staff to be off isolating. Because if every crew who had been in contact with a COVID patient had been contacted, that would have had an impact on staffing levels.
Yes. So how did staff respond then if they learned that there had been someone in the ambulance who had had COVID, when they learned of that? However they learned of it, what was their response to learning it?
I think.
What did they do?
I think by then they weren't surprised. I think by then, and everything that they had to fight to kind of get to protect themselves, some of our members used the expressions, they felt like, you know, lambs to the slaughter, and they just got on with it. If they felt okay, they got on with it. But it was so obvious to them that they just were not being part of that system.
Then in paragraph 56 of your statement, you refer to responsibility for cleaning ambulances.
Yep.
If staff learned that there was or might have been someone who had COVID in the ambulance.
So back at the beginning of the pandemic, after every patient, so you wouldn't know, the crews wouldn't know whether somebody was positive or not, but whether they had symptoms, after each patient was handed over to the hospital, the crew were expected to give the ambulance a good deep clean. Mm-hmm. They had been provided with more adequate cleaning products to do that. And, you know, as I said, it was after every patient that was expected of them. Then,
irrespective of COVID, whenever anyone had been in an ambulance, they were expected to do a deep clean?
Before COVID, they would be expected to clean the ambulance after every patient.
Yes.
But during at the beginning of the pandemic and during the pandemic, it was based as a deep clean, so it was a more thorough clean that they would have to do, and they had been given, as I said, a bit stronger, if you want, there's a better word, cleaning products to do that, which would to kill the infection bacteria, which was thought the original products wouldn't do. But then through time, those stronger cleaning products were taken away, maybe cost, don't know, and they were back to using the normal ones that they had been using prior.
What would the time scale of this be? Sorry, is this like during the first lockdown, or is this over an extended period?
During the first
Right. So
lockdown.
even during the first lockdown, it began with the usual cleaning products, then stronger cleaning products, and then back, even during that 4 months, back to the...
Yeah, because it was... The crews felt that this was to get them back on the road quicker. So as soon as you handed over a patient, and it might have taken you 20 minutes, half an hour to give it a deep clean, it would maybe only take you 10 minutes to just give it a once over, and you would then be, you know, letting the control room know that you were clear and you were ready to pick up the next patient.
I mean, it is true, my memory fails me, but it is true that I think it's around this time that there was more awareness or consciousness long waits for ambulances when people were called.
Yes,
Is that
yeah,
right?
that'd be right,
Yes.
yeah.
And would that would have been a result of some of these things?
Yeah, and that would be why the service would be trying to get the turnaround times to be, you know, that it is, the members felt that that was what was more important to the employer, was the turnaround times rather than their safety or their well-being.
Right, so they felt the message was that the turnaround times couldn't slip and that something else had to be, to slip.
Yeah.
Yeah. In paragraph 59 of your statement, you also mention interesting points about ventilation in ambulances. I mean, do you want to say something more about that?
Yeah, so the ambulance saloons have, which is the back of the ambulance, have a heater, if you want to call it, and the heater works through recirculated air within the back of the saloon. So our members, our fleet, we had asked for risk assessments because we had concerns that if somebody had been in that saloon as a patient and they had COVID, and as you've just said, at this time, you know, that we were starting to have a lot more people in the ambulances. We asked for risk assessments about the ventilation, and we were never given a risk assessment about the ventilation. And we had fleet people look at it as well, because of the regeneration of the air would mean that any droplets from one patient would then, as the ambulance started up, would just be regenerated about the back of that saloon and therefore cause further infection.
You said something important there, I think, about, I'm not going to get the expression right, but I mean, the throughput of patients in ambulances increased during the first lockdown.
Yes.
That's what you said, yes.
Yeah.
That's right. And yet, what I think you're saying is that no risk assessment was done.
The risk assessment
at the time
it wasn't done. From memory, I think the risk assessment was done about December 2020 or January 2021.
And can you remember what the outcome of that was?
I've got a copy of it. I don't think it addressed the concerns that we had at the time. It was, but interestingly, moving on from that, new ambulances don't have those style of heaters. The new ambulances actually bring in air from the outside.
But the risk assessment wasn't done until the end of 2020?
The end of 2020, January 2021.
Now, in paragraph 64 of your statement, you deal with the death of an ambulance worker. I mean, I think by that you mean that quite early on there was experience of a fatality of an ambulance worker?
Yeah.
Yes. And can you just say a little bit more about what you know of that?
Yeah, so sadly, again, this was at the beginning of the pandemic. This would be, I think it was March, mid-March. Some of the crews who work out in the rural areas have to bring serious patients more into the central belt, which can be a couple hours journey that the ambulance crew will be in the back of an ambulance with the patient. The person that we're referring to here had several, him and his crewmate had several concerns about the inadequate PPE that they were given, and I actually think they had to put up a bit of a fight within their own local area to get the PPE that they did eventually get, which was just the blue masks and the apron. And I know that this member did have conversations with his family that he was frightened about going out and doing his job with inadequate PPE, what that would mean to his family, what was he going to be bringing back to his family. And there had been, I think there had been two call-outs for that crew, or one call-out but two COVID patients. One was potential COVID, the other one was positive. So that was a 2.5-hour journey each way that ambulance crew had that patient.
Can I just ask you to pause there?
Yeah.
Is that an unusual experience for ambulance staff workers to be with patients for such a long time, doing a transport of such a long distance?
No, it's not unusual.
That's not unusual, yes.
No, not from the rural places, no. So, as I said, it would be 2.5 hours each way. I think a couple of days after that, the member was then diagnosed of having COVID, and shortly after that, he sadly passed away.
Well, thank you for that. Honestly, very sad experience. Now, that brings us to long COVID, and you say in paragraph 66 of your statement that long COVID is more prevalent for Scottish ambulance service workers because of the job that they did. I mean, do you, I'm not asking you for them, I mean, but you are able to support that statement?
Yes, I'm able to support it because of the members that we represent and the members that we've been representing since the pandemic that have long COVID, and it has an impact on them doing their job to the extent that, sadly, you know, some people are just no longer capable of carrying out that job, and we're having to deal with a lot of our members facing the case of their employment being terminated. So we deal more with that than we are in the NHS. But then I don't know, you know, I don't know in the NHS with nurses, is that more, and you know, one of the other bigger unions might have a bit more knowledge about that, but definitely within the ambulance service, it has become a big thing.
Right, so there is, you're able to say that there is a particular impact on ambulance service workers, your membership, ambulance service workers, from long COVID, than there is in your experience from other workers in the healthcare sector.
Yes, and I think partly that's about the fact of the job that they do and the fact that long COVID, I know it has a lot of different impacts on people, but people do suffer from respiratory problems with long COVID, and that therefore stops them being able to do the job that the ambulance service would do when it comes to heavy lifting, going upstairs to visit patients when they're in, you know, some people in tenement buildings and things like that, and the equipment that they've got to carry as well. It can have a huge impact, and there's not so many alternative jobs that the workforce in the ambulance service can do as opposed to the wider NHS.
Towards the end of this section at paragraph 68 to 69, you mention specifically mental health impacts. I mean, it follows from what you've been saying in the last 10 minutes or so that there were obviously physical health impacts from COVID and continuing ones from long COVID. But you do specifically address mental health impacts. Do you want to say a little bit more about what they are and how lasting you think they are?
I think it varies from the stress and the anxiety that the crews felt just carrying out their job, but also with some of the things that they had to see and deal with. Also, the lack of support from their employer has a huge impact on people's mental health and well-being, because a lot of the time it was deemed as you just need to get on with it. Our members didn't feel that the support was there from their employer. They felt really, really vulnerable throughout this whole time, and that is having an impact on their well-being.
Would there be also frustrations in dealing with people who are ill, if the ambulances, it takes a long time to get to them, for example, that they have to deal with the patients and their families?
Yes, yeah. That's always been a bit of a stress for them, but yeah, more so in this time.
Well, thank you, Mrs. Leonard. I did say we were going to spend quite a lot of time on what you had to say about the impacts of COVID on your members in the Scottish Ambulance Service. And in the time available, we are inevitably going to spend less time on the impacts on your members who work in the NHS. And that's not to say, of course, that their impacts are any less important, but you'll understand that the inquiry has heard quite a lot about that already. But I mean, would it be a fair summary to say that much of what you've been saying about the impacts on your members in the Scottish Ambulance Service would be also felt by NHS staff members?
Yeah, absolutely. They had the same problems with the PPE at the beginning. They had the same problems with staffing levels. Obviously, the amount of patients to some extent had increased. So there was different pressures for the workers in the hospitals, in the NHS, to the ambulance service, but still amount to the same, where we have NHS workers who have got the same, long COVID, not as many, but mental health problems, felt the same kind of vulnerability as the Scottish Ambulance Service did as well. And the NHS workers were spending longer times with COVID positive patients because they would be in wards with them. So again, it had different pressures.
I mean, in relation to PPE, you make the point in paragraph 75 of your statement. You refer generally to domestics. I mean, by that you mean support staff and porters and cleaners and so forth. That, as the inquiry has heard before, but it would be true of your members, would it, that the proper PPE and the most effective masks weren't issued beyond clinical staff until later?
Yeah, and I'm kind of trying to think now, even if they were. Ever. We had members who were having to go into wards and rooms to again do a deep clean after a COVID patient. And again, sometimes they weren't told, and I think that was because of the lack of the adequate PPE. There was sometimes they weren't actually told that they were going into clean a room that a COVID patient had come from, and a lot of the time they would maybe only know it because of the gowning the surgical and the nursing staff had on, that would indicate to them that there had been a COVID patient in there.
Yes.
Well, it's just shocking.
Just before we move on, just a little earlier in your statement, paragraphs 71 and 72, I think what you're referring to there is when you say the heading is flexibility. And here you're dealing with both with the NHS and the Scottish Ambulance Service. What I think you're saying is working conditions depended on the particular employer or particular management practices. So, for example, you say there were certain matters. Well, you talk about issues around transport, childcare issues affecting workers and their abilities to work. And these matters gave rise to day-to-day conflicts with some. I think you mean by that some managers being unsympathetic.
Yes, absolutely. Yes.
Was this matter a subject of guidance, of requiring managers to be sympathetic to these matters?
Yeah, I'm sure there would have been their own policy just now. Their basic staff governance would talk about flexibility and how you should be treating everybody in an individual basis and look at all these issues. But there was, and again, I'm going to have to say that a lot of these problems and a lot of people who were affected by this were the facility workers. They were our porters and our domestics and our catering staff.
There was less flexibility for them.
Less flexibility.
Yeah. Now, in paragraph 78 to 82, you discuss issues such as the lack of risk assessments. That was of concern to the GMB, and that was true in relation to most NHS health boards.
Yes.
There being lack of risk assessments. And in paragraph 82, you say that changing guidance didn't filter down throughout the workforce, which I think is a point you mentioned at the beginning on communication.
Yeah, and again, that would be about the guidance, and that would be from the outset of where was the high risk, how was that supposedly to be dealt with, and how would people move on. I think at some point in my statement, to just to give you a kind of example, there were nurses who were working in both they had them as red zones, which would be a COVID ward, and a green zone, which would be a non-COVID ward. And there were nurses and, again, health support workers and facility staff who would be expected to work in both those zones in one shift.
Yes.
And that caused the workers, again, a lot of fear and anxiety.
If we can just to turn to that right away, when you talk about NHS nurses specifically, you give, in fact, 3 examples. And the one you've just mentioned there is example 2, which is at paragraph 87, which is, I think, a problem of overlapping duties in different areas of work, or overlapping different areas of work. So people would move between different zones without having any change of PPE
or uniform.
Yes.
And that was down to staff shortages.
And was that something particularly true at the outset of the pandemic, or did it continue throughout?
It continued.
And then example 1, so if we call example 2 a sort of overlapping duties of moving between zones without changes of PPE, in example 1 at paragraphs 84 to 86, you're addressing their deployment issues and the problems that gave rise to for nursing staff. In that, I'm summarising, but I think what you're saying is that people were, because of shortages of staff and people off or shielding, nurses were deployed into areas of the clinical setting that they weren't used to.
Yes, we had, well, the example I used there was a group of our members who were theatre nurses, so predominantly working in the theatres, and not been working in wards for some time. And as well as the things you say about the staff shortages, and it was also about the lack of beds and these COVID wards, the availability of them in some of the boards. So what boards were doing were closing some wards, making them COVID-specific wards, but then never had the staff to staff them, because these were additional wards within certain hospitals. And they then were looking at redeploying groups of workers to go into that ward and be the responsible nurses for those patients. And that caused a lot of distress for our members, because, again, I mean, as well as working in the environment that they would be in, this was taking them out of their natural zone of the work that they had been doing, sometimes for like 20 odd years, where they hadn't worked in a ward environment. And that was causing a huge amount of distress to the workforce, that they were then being told, this is what you're going to do. We're going to open this ward, we're going to move you to another hospital, and it's your responsibility to look after these patients. I have to say that the GMB did step in this case, and that never went ahead, and those group of workers weren't deployed there. But it was the impact it had on them. You know, this was maybe like a week where they didn't know. It was issues about, well, doing the job that they hadn't done for ages, relocating, travel issues, what it would, because it was a whole shift change for them.
Yes.
So, you know, again, it was just felt as if there had been no communication. There had been no communication with the membership, consultation with the unions. We just got a phone call from a group of our members saying, this is what they're telling us they want us to do as of next week.
And there was no consultation with the union beforehand, which you would have expected in normal circumstances.
Yes.
Yes. And then finally on your examples, example 3 is another type of deployment problem, which is newly qualified nurses being asked to work in the ICU.
Yeah, I mean, I don't have a great deal of information on that, other than, again, it was pressure that newly qualified nurses would go through a period where they would be mentored, they would have the support there of their more experienced colleagues, but because of staffing levels, they would again be just put into, you know, intensive trauma units and expected just to get on with the job. And I think we had some members that were really put off by that, put off their career by that.
And then the final part of your statement on NHS impacts deals with the, I suppose, a combination of issues, but related issues relating to staffing levels because of people being absent and the burden inevitably falling on those who are at work, leading to greater stress. You also, I think, suggest in paragraph 93 of a problem of absent managers. I mean, is that because administrative managers would work at home, or was there more to it than that?
There was more to it than that. We had a few reps actually who had experienced this, where it was the clinical managers who would maybe have a lot of admin as part of their role, who would normally be in the hospital environment, were actually working from home. So it was felt that whilst there was a shortage of staff and the additional pressures on the workforce, it was felt that the managers, the higher managers within the clinical profession, weren't rolling their sleeves up and getting involved. It was felt by our members that their managers could have done more to be helping them out when they were in short staff and sometimes unsafe environments. They felt like they weren't all in it together.
Right. And then finally, in relation to special COVID leave, I mean, that was something that was ultimately authorised by the Scottish Government.
Yes, they introduced it.
But the practice on the ground was often very variable, is that right? In that some employees had the benefit of it and some didn't.
I think eventually they probably all did, but again it would come from the trade union reps having to pursue that with certain boards and certain managers and certain departments. Now, whether that was because the guidance from the Scottish Government didn't get down the levels to the local managers, I don't know, but there was a problem with people not getting that special leave, as it was then called at the time. And the purpose of that was so that there was no absence trigger that would take, you know, if you got COVID a couple of times and you would then trigger an absence to look at your capability and things, that was to stop that from happening. So it was really a welcomed introduction at the time by the Scottish Government. And when we kind of, after a few months of the trade unions maybe having to educate the employers about this is what they should be doing to their staff, that did work. But then it was just taken away, like it was just put in. And so now we have circumstances where even when COVID has been around and comes back and forth, they no longer have that anymore.
No. But potentially some problem of communication at that level as well.
Yeah.
Yes. Well, turning then briefly to the impacts on NHS 24 workers. So if you could just briefly explain what the particular context of NHS 24 workers is here.
So the NHS 24 workers are working a call centre environment is the best way I can describe it. And they work in shifts, they work in clusters of groups of workers very close to one another. They take the emergency calls, they take 111 calls, the varying different calls and emergency calls as well.
And they need to be at work.
And they need to be at work, So it became, again, there was concerns there because they were being told they weren't entitled to PPE in the workplace because they weren't patient-facing. So even although they were asking for masks just to be safe from their colleagues and stop spreading anything or whatever, that was a bit of a fight to get that. When the guidance came in, and so because they're quite small places, so whilst we were all, even before guidance came out about social distancing, people were naturally just distancing yourself from folk. They felt that they couldn't do that. The nature of their job as well, where they're taking calls, there's nurses that kind of float about within the call centre who have to look over your shoulder, look at like a screen that I'm looking at, and maybe be quite intense in workspace. So we'd asked for changes on that. We'd asked for risk assessments. None of it was done. We'd carried out, again, it got to the point where we had to carry out a survey when the 2-metre distancing guidance came out, because the employers, NHS 24, refused to implement the 2-metre distancing. I think at that point they then decided they'd give them a blue mask, and that should keep them happy. But the workforce there were absolutely terrified. And we did the survey. We were 90%, 100% people petrified in the workplace. We then had to then write to the Scottish Government again and go to the Cabinet Secretary again. And this would be about April, May time. So you were probably a good few weeks into lockdown before the 2-metre distancing was actually put in place within the NHS 24 buildings.
So what it comes down to, I think, is a particular problem for NHS 24 workers who have to be at work,
Yep.
is that in addition to certain other problems that others face, like problems with PPE and accessing PPE, a particular problem was confusion about the social distancing rule that was to apply, whether it was to be 1 metre or 2 metres. And would you say that it was the union's intervention at the end of April 2020 in escalating this up to the Cabinet Secretary for Health that resolved this?
Absolutely.
As soon as it did?
No, absolutely, but I don't think there was confusion. I think they were just blatantly not prepared to do it because of the lack of space. Because what that would also mean as well would be they would have, it would have created for the employer issues around how many staff could be in the building at any one time. But that was down for them to manage, and there was ways that they could manage that, and they were just at the beginning refusing to look at anything.
So could it be put that a lack of thinking outside the box?
No comment.
Right. You mentioned in paragraphs 105 to 109 various surveys, and you've already referred to some of them, but the GMB continued to conduct surveys of members, or particularly around the effectiveness of health and safety measures and availability of PPE. I'm not going to take you through them, but I mean, is there anything you would want to particularly highlight about those surveys that you mentioned in your witness statement?
Yeah, the fact that the continuity of the lack of PPE. So when we surveyed them in March, surveyed them in July, and then do surveys towards the end of the year, there was a theme that was reoccurring across the whole of NHS, and it was, do you feel protected in your workplace? No. Do you feel supported by the management in your workplace? No. Do you feel that you have had adequate PPE? No. Everything was coming, and these surveys were coming back with a good response, and always been 90% plus in that. So from like nearly a year on, how people felt at the beginning is still how they were feeling.
Well, you do say in paragraph 109 in January 2021, even then 61% said no, they were not satisfied about being safe with their current PPE.
Yeah.
Now, as with other witnesses to the inquiry, Mrs. Leonard, you're asked to say something about lessons to be learned, and you deal with this in paragraph 110 and 111 of your statement. If you were to identify two matters from the experiences that you've been speaking about across your membership that you would hope would have been learned from the pandemic, what would you say they were? It doesn't have to be two, it can be one if you want to, in the time available.
I think I think it's obvious, and I think our members in the NHS workforce would also say that it's really important to have the trade union impact in the workplace at all times, and if none more than this, because a lot of the times it was the only way that these workers were getting the information, which they got the information in order to make them protected in the workplace. And unfortunately, it does go back to, it was a lot of people who were carrying out the lower paid jobs, who felt kind of left out. So I think that there has to be a lesson learned in that everybody gets treated the same, fairly and equally going forward.
I mean,
obviously the PPE issue, but...
Yeah, I was going to say the availability of technology for all staff to be communicated digitally with.
Yeah, yeah. Not just technology-wise. I think just from a morality-wise of just treating people, acknowledging that the worker, I mean, these were frontline workers who were out there day in and day out and were prepared to do that job regardless of what circumstances, because that's the job that they did, and they felt that these patients needed them. But there was never ever any support for those workers. They never ever felt that they were getting the support that they were actually giving their patients. I think that has to be looked at.
My Lord, Mrs Leonard, your witness statement and your evidence today will stand as your evidence to the inquiry. Is there anything else you would like to add?
No.
No. Well, thank you very much for your clear-sighted evidence, and that concludes Mrs Leonard's evidence today, my Lord.
Thank you very much indeed, Mr Edwards, and thank you, Mrs Leonard. And that concludes proceedings for today. We're not sitting tomorrow. I don't actually know offhand what time we're starting on Friday morning, but no doubt you will be told. Thank you very much.